video is brought to you by Dr. Barai. Please press on the subscribe button and the bell icon.
Hello everyone, and this is Abhijit Barai. In this video tutorial we are going to talk about second degree heart block. Many of you have asked about the differentiation between Mobius type 1 and Mobius type 2, and so we are going to show you a lot of ECGs and animations to explain these different types of second degree heart block. I hope you find this useful. Now in this video I've got Becky with me, who is going to interpret the ECG in a very systematic way so that we don't miss the important parts. Welcome Becky, thank you for being with us.
Hello everyone. I am Becky. As always, I am very excited to be here. Over the next few minutes, we are going to show you some awesome ECGs with a lot of animations and up-to-date information. Hope you like it. I know how amazing you are. Please press on the subscribe button below and do not forget to click on the bell icon to get regular updates. We will bring to you new exciting videos regularly for your education and entertainment. If you have any burning questions or awesome ideas, please write in the comments section below and we will get back to you as soon as we can. I can assure you that the next few minutes will be brilliant. I will be with you till the end of the video. Let's start, shall we?
Absolutely. So let's get into a case that we have seen recently. So it's a 67-year-old man who has got some intermittent palpitation and chest tightness. Now in elderly patients, sometimes tightness of the chest can be because of myocardial ischemia. Palpitation can be subjective. So some people will say that the heart is racing. Some people will say that there is some drop bit. Some people will say there is some fluttering feeling in the chest. So when the patients say I've got palpitation, we need to ask them a few questions to identify exactly what they meant by palpitation. This particular patient was on aspirin, some diltiazem as a calcium channel blocker, and also was on simvastatin. He lives alone and he's self-caring, which is good. Now on examination, it was found that the patient was epiaxial with a normal temperature, respiratory rate was normal, saturation was pretty good for a 67-year-old. I hope that he is a non-smoker. His heart rate was 78 beats per minute, and the blood pressure was a little high than expected. Temperature was normal, and his GCS was 15/15, which is fantastic. So for the assessment of this patient and to find out what is going on, we did one ECG, and this is the ECG which look like. Now we will interpret this ECG in a very systematic way in a few minutes, but for the audience I would suggest press on the pause button in your video player or in the YouTube or other players, and then interpret the ECG in a systematic way. And I have got a different video where I have shown how to interpret an ECG, and if you follow those steps every time, you will not miss any important findings. Now obviously what we can see in this particular ECG is that there's a bit of sinus rhythm, but also there is an intermittent non-conducted P wave. So this is a second degree heart block. Some people call it a secondary atrioventricular block. Personally I don't like it, because if I say atrioventricular block, it gives the impression that the block is at the level of the AV node, which may not be the case. So the block can be at the level of the AV node, it can be in the bundle of his, it can be in the right bundle branch, left bundle branch, Purkinje fibers. So I personally prefer to call it a second degree heart block rather than second degree atrioventricular block or AV block. But in most of the medical literature they call it a second degree AV block or second degree atrioventricular block. That is absolutely fine. Right, so what is a second degree heart block? So the main thing with the second degree heart block is the non-conducted P waves. So you will see that in the ECG that I have just shown you, that there is a P wave followed by QRS complex, P wave followed by QRS complex, and suddenly there is a P wave which is not followed by QRS complex. If you find that pattern in the ECG, non-conducted P wave, that means there is a second degree heart block. This is not a first degree heart block. This is not a third degree heart block, because there is association between the P wave and the QRS complexes. Now there are two types of the second degree heart block. One is the Mobius type 1, which is also called Wang-Batches block. The characteristic feature here is that the PR interval progressively prolongs and suddenly there is a non-conducted P wave. It can happen in every alternate bits, or it can happen in every second bit, or third bit, or fourth bit, or fifth bit. So the main thing with the Mobius type 1 is that the peer interval gets prolonged, and then there is a non-conducted P wave. In Mobius type 2, however, the peer interval is constant, no prolongation of the peer interval, but still there is non-conducted P wave here. So we'll talk about the differences between. There are a lot of differences between the Mobius type 1 and Mobius type 2. There are differences in the ECG, there is difference in the management, there is differences in the ultimate outcome as well. So a little bit of background about ECG. So when there is some electrical activity in the heart, we can pick it up by putting some electrodes on the surface of the body, and the computer can analyze this and give us a picture, and that picture is the ECG. Now what the lead tells us, the lead is the point of view. If you look at the heart from a particular point of view, say on the right side, left side, under surface, or from behind, then you will get some electrical graphical picture, and that is the lead. Please don't get confused between the lead and the electrode, because electrode is that sticky bits which are connected on the surface of the body. That is not the lead. The lead is the computer is giving you a picture from a particular point of view. For example, if I say lead AVF, it means what is happening to the undersurface of the heart. If I say in lead 7, 8 and 9, it means what is happening to the posterior aspect of the heart. So that is the lead, not the electrode, because we don't put the electrode at the same level at the lead. Conventionally, in a 12 lead ECG, we have got 6 limb leads and 6 chest leads, but you can get more leads, you can get less leads depending on what you are looking for. For example, if you want to look at what is happening to the right surface of the heart, we have got one ECG, 12 ECG, that I will show you in a minute. If you want to see what is happening to the right surface of the heart, you can do V4R. If you want to see what is happening to the posterior surface of the heart, you can do V7, V8 and V9. If you are interested to know if there is atrioventricular dissociation, like in case of a VT, or in case of a complete heart block, or even in case of the second degree heart block, you can do a Lewis leads. Now let's show you a normal ECG, and I will show you some animations to understand exactly what happens to the normal ECG. Then that will be easier for us to understand what happens to the second degree heart block. So let's get oriented with this picture and the animation. So this is the right atrium, this is the superior vena cava here. At the site of junction between the superior vena cava and the right atrium, there is the SA node, and then these are the yellow areas, these are the conduction system of the heart. There are 3 internodal pathways, so this one, here and here. Now when the cardiac impulse is generated, usually this is generated at the fastest rate in the SA node. That's why the SA node is called the pacemaker, it's the team leader. And then the cardiac impulse goes through the internodal pathways into the AV node. Because there is some refractory period in the AV node, there is some atrioventricular delay. Now after this, a cardiac impulse goes to the bundle of His through here, and then through the right bundle branch and left bundle branch, and then Purkinje fibers, and then it goes to the cardiac ventricular muscle fibers, and essentially there is depolarization of the ventricles. So this is what happens in a normal looking ECG. So as you can see that there is this cardiac impulse transmitted, and Becky is going to talk about it in a little bit more details, but let me show you the peer interval. So peer interval is from the beginning of the P wave to the beginning of the QRS complex, this bit. In another video, I have shown you what happens in the first degree atrioventricular block when the peer interval prolong is very high, it is more than 200 millisecond. And in another video, we have got third degree heart block where we have shown that the peer interval is not constant, it varies because there is no correlation between the P wave and the QRS complex. Now for the second degree heart block, the most important part that you should look for is the peer interval. I mean, every part is important in the ECG, but the peer interval will give you the most important information to get into the depth of the second degree heart block. So Becky, could you please tell us a little bit more about the conduction system of a normal ECG so that we can understand a little better? Thank you.
This is the normal cardiac activity. The SA node is the pacemaker of the heart. It generates cardiac impulse at the normal rate of 60 to 90 beats per minute. The cardiac impulse then passes through the interatrial pathways to the AV node where there is some delay. You can appreciate it here. In the ECG, there is a PR interval due to the AV nodal delay. This is followed by the conduction of cardiac impulse through the bundle of His into the right and left bundles and Purkinje fibers and cardiac myocytes. In the ECG, the P wave represents the atrial depolarization, the PR interval is the AV nodal delay, the QRS complex is the ventricular depolarization and the T wave is the ventricular repolarization. This goes on and on and on. So, the normal ECG is very easy to comprehend. One thing needs to be remembered is that the positive deflection of the ECG means that the cardiac impulse is passing towards the lead. On the other hand, a negative deflection means that the cardiac impulse is passing away from the particular lead. Excellent stuff, isn't it?
Absolutely fantastic. So that is a normal ECG, and if you can understand this, you will be able to understand the second degree heart block as well. Right, so let's show you the second degree heart block. As we have mentioned, there are two types of second degree heart block, Mobius type 1 and Mobius type 2. So at first, I'm going to show you Mobius type 1. Mobius type 1 is when there is progressive prolongation of the PR interval, and it will be followed by a non-conducted P wave. So this is the, once again, this is the same type of animations. So what happens here is that there is a P wave followed by QRS complex, then there is a P wave followed by QRS complex, then there is a P wave followed by QRS complex, then there is a P wave followed by QRS complex, and then the number 5 P wave is followed by no QRS complex. So this is a 5:4 second degree heart block, or Mobius type 1 heart block. If you carefully look at the PR interval here in the first cycle and the PR interval in the fourth cycle, you can appreciate the difference between the first PR interval and the second. So if you carefully look at it, the PR interval progressively prolongs, and then there is a drop bit or non-conducted P wave. Now what happens in the heart? So once again, then like a normal patient, the SA node is generating cardiac impulse 1, 2, 3, 4, and then the fifth one, it does not conduct. So can you see that? So this is the third one, this is the fourth one, and then fifth one is not conducted, and that is when we call this a Mobius type 1 heart block. So once again, the cardiac impulse is generated in the SA node, it is going to the AV node. Not all the cardiac impulses are transmitted, most of them are transmitted, but in every 4 or 5 beats it's just stays there. It does not go any further because there is a block. Now usually this type of block happens at the level of the AV node, and that is why the QRS complex are narrow complex, but it can happen to other places as well. If the block is below the AV node, like bundle of His or right bundle branch, left bundle branch, usually the QRS complex is wide complex. So the one way we can differentiate between the Mobius type 1 and Mobius type 2 is by looking at the morphology of the QRS complex. Like here, the QRS complex is pretty narrow complex. That is why this is the Mobius type 1 block. But in the next one, I'll show you what happens in Mobius type 2 when the QRS complexes will be little wide. All right.
That makes sense. Thank you.
No worries. So let's go to the Mobius type 2 now. So what happens in Mobius type 2 is similar like the Mobius type 1. The difference here is the PR interval does not get progressively prolonged. The PR interval remains constant. And just like in Mobius type 1, here also there will be a P wave followed by no QRS complex. So there is a non-conducted P wave. It can happen in different ratios. It can happen in 1:1. So for every 1 P wave there is a QRS complex, not 1:1. Usually it happens 2:1, 3:1, 4:1, 5:1, 6:1 block. If it goes beyond 6:1 block, sometimes it can be unpredictable, high grade block. So let's keep it simplified. So Mobius type block is when, as you can see here, there is a P wave here followed by QRS complex, then there is a P wave followed by QRS complex, then there is a P wave followed by QRS complex, then there is a P wave, no QRS complex. And if you carefully look at it, the PR interval is not progressively prolonged, unlike in case of the Mobius type 1 block. So this is Mobius type 2 heart block, or some people call it Mobius type 2 atrioventricular block, where the PR interval is constant, and for every 4 P wave there are 3 QRS complexes. And if you carefully look at it, the QRS complex is a little wide, not massively wide. I have got another rhythm strip that I will show you shortly, where the QRS complex is pretty wide. So what it means is that block is somewhere here in the bundle of E's. If the block is here, then the QRS complex will be massively wide, right? So in the animation, let's have a look at it again. So for every for the first bit, it is transmitted. The second bit, it is transmitted. The third bit, it is transmitted. And the fourth bit, it is not transmitted. So let's go through again. First bit is transmitted. Second bit, it is transmitted. Third bit, it is transmitted. And fourth bit, it is not transmitted. So there is a P wave, but no QRS complex. All right. So there is a little...
that makes sense.
Yeah, absolutely.
Thank you.
No worries. So there is some subtle differences, and we'll show you a little table form between the Mobius type 1 and Mobius type 2. But if you can understand those little animations, you will be able to have some idea what happens in the underlying pathology. That the SA node is generating cardiac impulse, but not all of them are transmitted through the AV node and bundle of his, and that is the second degree heart block. Now let's show you some 12 lead ECG and some rhythm strips, and Becky is going to interpret this in a very systematic way so that we don't miss anything. All right. Before we go that, let's do a quick recap that whenever you look at the ECG, use this little watch that I have prepared for you. It takes about 20 to 30 seconds to read one ECG. The first thing you look at is the rate. Two types of rates are there. One is the atrial rate, the other one is the ventricular rate. There are different ways of calculating it, and we have got a different video to explain those. The second you look at is the rhythm. Is every P wave followed by QRS complex? Is it a sinus rhythm? Or if it is not a sinus rhythm, is it irregular, and is it an atrial fibrillation? Is it atrial flutter? Is it irregular means because there is an atrioventricular block? Is it a third degree block? So that is the rhythm. Then axis. You can look at the axis for the P wave, you can look at the axis of the QRS complex, but usually we just look at the axis of the QRS complex. Look at lead 1 and look at AVF. That will give you some idea. Is it normal axis? Is it left axis deviation? Is it right axis deviation? Is it extreme axis deviation? After that, look at the PR interval. So when it comes to the interpretation of an ECG for a second degree heart block, PR interval will give you the most important information. So as we have mentioned earlier, that in Mobius type 1, that is progressive prolongation of the PR interval followed by non-conducted P wave, and for Mobius type 2, there is the PR interval is constant, but still there is non-conducted P wave. Now please don't get confused between the PR interval and PR segment. From beginning of P wave to the beginning of QRS complex, that is a PR interval. But PR segment is from the end of P wave to the beginning of QRS complex. The only time the PR segment is important is in case of the pericarditis. Also sometimes in myocardial ischemia, the PR segment may be depressed. Once again, PR interval is the most important information that you will get for second degree heart block, both in case of Mobius type 1 and Mobius type 2. Sometimes we say that there is a gold mine in the QRS complex, and that is true for Mobius type 1 and Mobius type 2 heart block as well. Conventionally, in Mobius type 1, QRS complex is narrow complex, as we have just mentioned earlier, because the block is at the level of the AV node. Because the Mobius type 2 has got the block down below the AV node, the QRS complex is wide complex, usually, but not all the time. So that will give you some rough idea, but it is not confirmatory and it is not definitive in 100% of the cases. ST segment is important because if the patient has got ST segment myocardial infarction or a STEMI, they can have ST elevation, and I have got one 12 lead ECG with ST elevation and the second degree heart block. So please don't forget to look at the ST segment even if you are focused on the PR interval, because this is a second degree heart block. You will get some very important information from the QTC that will give you some idea about the electrolytes, that will give you some idea about the drugs, that will give you some idea about even myocardial ischemia. So I'm talking about QTC, which is from the beginning of the QRS complex to the end of the T wave. After you are happy with the QTC, then look at the AVR. Please don't forget AVR, because AVR can give you some very important information as well. There are some fine prints, like does the patient has got a right bundle branch block, left bundle branch block, is there any ROA progression in V3, does the patient has got Scarbosa criteria, or is there any pacing rhythm. So there are a lot of important things, but they don't get the priority. The priority are those few things. Once you get all the information, please correlate the ECG findings with the patient's findings. How old is the patient? What are the demographic characteristics? What are the underlying medical conditions? What is your plan about the management of this patient? Is the patient going to the cath lab, or does the patient need some going to ICU for dialysis, or does the patient need some electrolytes like the potassium, or maybe calcium gluconate, hyperkalemia? So that is a synthesis. So once again, whenever you look at the ECG, look at the rate, look at the rhythm, look at the axis, PR interval, especially in case of the second degree heart block, look at the QRS complex, narrow complex, wide complex, look at the ST segment, QTC, AVR, and other weird and wonderful things, and then correlate those findings to the patient. So to do this, it will take about 20 to 30 seconds, and if you do this every time, then you will get a very good idea about that 12 lead ECG, and Becky is going to interpret those ECGs that we have in that systematic pattern.
Awesome. Really interesting.
Absolutely, very interesting, and you are going to tell us about some of the ECGs. Okay, so let's go through this first ECG that I have shown you in the very first slide. So this is a 12 lead ECG. There are 6 limb leads and 6 chest leads. And Becky, could you please interpret this ECG in a systematic way that I have just told you about, and so that we don't miss anything. All right, the floor is yours. Thank you.
This is a great ECG, Avijith. Thank you. I am going to interpret this ECG in a very systematic way. However, if there is an elephant in the room, that does not need an introduction. The elephant in the room in this ECG is non-conducted P waves suggestive of a second-degree heart block. I will come back to it in a second. Let me talk you through the usual stuff at first. The ventricular rate is 66 beats per minute. Every P wave is followed by a QRS complex. However, there are intermittent non-conducted P waves. The QRS complexes are irregular. Now, the axis of the QRS complexes is about +80 degree, which is normal. The P wave is normal and the PR interval progressively prolongs, followed by intermittent non-conducted P waves. For every 5 P waves, we have 4 QRS complexes. Therefore, there is a 5:4 Mobitz type 1 second-degree heart block. The QRS complexes are narrow complex and irregular. The ST segments are isoelectric. The T waves are normal. In lead AVL, there is T wave inversion, which may be an early sign of inferior myocardial ischemia. The QTC is about 360 milliseconds, which is normal. The AVR lead looks reassuring to me. Now to compile all these information together, I am of the impression that the patient has a Mobitz type 1 second-degree AV block. I am a little concerned about this patient. My immediate action would be to seek and treat the underlying cause. For example, the patient may need further workup from myocardial ischemia point of view.
Absolutely. So that is absolutely comprehensive, succinct interpretation. And if we do the interpretation of the 12 ECG just like what Becky has done, then we will not miss any important information. So a couple of things here: narrow complex QRS, and if we look at the PR interval, so there is a P wave here, and then there is a P wave here, then we have got another P wave here, and then we have got another P wave here. So every P wave is followed by a QRS complex, except the 5th P wave, which is not followed by a QRS complex. And if you carefully look at the PR interval here and PR interval here, you see that there is progressive prolongation of the PR interval. So that is classic Mobius type 1 second degree heart block. This is also called Weng-Batches block. Now, should we be worried? Well, the main worry that we have is here. So there is some T wave inversion, there may be subtle ST depression in AVL, which suggests that patient might have, not confirmatory, but might have inferior myocardial ischemia. So that patient will need further workup. So please, if you see the Mobius type 1, sometimes it can be just physiological. In athletic patients, for example, Mobius type 1 heart block, you don't have to do anything. But if you see a T wave inversion in AVL, then you need to take it very seriously, and it may be something really not good. It can be a nasty one. Now this is another one, so let's do the second ECG. So it is similar like the first one. There are some subtle findings, and Becky, could you please interpret this ECG in a very systematic way, just like you have done the previous one? Thank you very much.
This is another exciting ECG, Avijith. Thank you. As always, I am going to interpret this ECG in a very systematic way. The elephant in the room in this ECG is non-conducted P waves suggestive of a second-degree heart block. I will come back to it in a second. Let me talk you through the usual stuff at first. The ventricular rate in this ECG is 72 beats per minute. Every P wave is followed by a QRS complex. However, there are intermittent non-conducted P waves, which makes me wonder if it is a second-degree heart block. The QRS complexes are regularly irregular. Now, the axis of the QRS complexes is about plus 60 degree, which is normal.
Yeah.
The P wave is normal and the PR interval progressively prolongs, followed by intermittent non-conducted P waves. Just like the previous ECG, in this ECG too, we have 4 QRS complexes for every 5 P waves. Therefore, there is a 5:4 Mobitz type 1 second-degree heart block. The QRS complexes are narrow complex and regularly irregular. The ST segments are isoelectric. The T waves are normal. In lead AVL, there is T wave flattening, which may be an early sign of inferior myocardial ischemia or hypokalemia. The QTC is about 480 milliseconds, which is at the upper end of normal. The AVR lead looks reassuring to me. Now, to compile all these information together, I am of the impression that the patient has a Mobitz type 1 second-degree AV block. I am a little concerned about this patient. My immediate action would be to seek and treat the underlying cause. For example, the patient may need further workup from myocardial ischemia point of view. However, in a fit and well-healthy athletic person, this may be a completely normal finding with a very good prognosis.
Thank you very much. So that was absolutely brilliant interpretation. Now, a couple of things we need to consider here. First of all, yeah, absolutely, this is correct that there are so there is a P wave followed by QRS complex, 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 and the fifth P wave is followed by no QRS complex. So this is a 5:4 Mobius type 1 second-degree heart block. So if you carefully look at it, the PR interval is progressively prolonged, which can be appreciated by comparing the PR interval in the first cycle and the fourth cycle. Now, what is the difference is a couple of things. So here this is 5:4, but here there is one P wave followed by QRS complex, second P wave followed by QRS complex, third P wave followed by QRS complex, fourth P wave followed by QRS complex, fifth P wave followed by QRS complex, and then is a sixth P wave. So this is 6:5 atrioventricular block or heart block. So still it is a Mobius type 1 atrioventricular block. The second additional finding is, if you carefully look at it, there are some voltage criteria for left ventricular hypertrophy. So if you add up the S wave in V2 with the R wave in V4, you will see that there is some features of the left ventricular hypertrophy, and also the R wave in AVF, that is quite tall. However, the R wave in AVL is below 11 millimeters. So I still feel that there may be some features of the left ventricular hypertrophy, and this patient definitely will need echocardiogram and maybe some electrophysiological studies to see what's going on. All right, thank you very much. So we have talked about the P wave coming in pretty regular intervals. So sometimes this P wave can be fused with a T wave, and sometimes it can be very difficult to identify that P wave which is buried. So what you can do is identify the P wave and identify the PP interval, and usually from the PP interval we can predict where the next P wave is. So this is another interesting ECG, and Becky is going to talk us through the findings of this interesting ECG. Becky, this is all yours. Thank you.
This is a very exciting ECG. Thank you. I am going to interpret this ECG in a very systematic way. The elephant in the room in this ECG is ST segment elevation in the inferior leads and the non-conducted P waves suggestive of a second-degree heart block. I will come back to it in a second. Let me talk you through the usual stuff at first. The ventricular rate is 48 beats per minute. Every P wave is followed by a QRS complex. However, there are intermittent non-conducted P waves. A lot of them. The QRS complexes are irregular. Now, the axis of the QRS complexes is about plus 30 degrees, which is normal. The P wave is normal and the PR interval progressively prolongs, followed by intermittent non-conducted P waves. It is not very easily identified. In the 5th and 6th beat of the rhythm strip, there is obvious progressive prolongation of the PR interval followed by a non-conducted P wave which is buried in the T wave of the 6th beat. It is very subtle and can easily be missed. Obviously, this belongs to the Mobitz type 1 second-degree heart block. The QRS complexes are narrow, complex and irregular. The ST segments are elevated in the leads 2, 3, AVF and V4R. There is reciprocal ST segment depression in leads 1, AVL, V1 and V2. This suggests an inferior myocardial infarction. More specifically, there is a right ventricular myocardial infarction, probably due to the right coronary artery block. The T waves are normal. The QTC is about 400 milliseconds, which is normal. The AVR lead looks reassuring to me. Now to compile all these information together, I am of the impression that the patient has an inferior wall myocardial infarction associated with a Mobitz type 1 second-degree heart block. I am very concerned about this patient. My immediate action would be to activate cath lab for the reperfusion therapy. I would like to stabilize the patient as we are waiting for the percutaneous coronary intervention. This is a good example of Mobitz type 1 heart block due to myocardial infarction.
Excellent. So that is really good. Spot on. All the findings are there. Now this is a 12-lead ECG, but what is additional is we have got the V4R, so that will show exactly what is happening to the right surface of the heart. Now let's get back to the main feature. So there is a P wave here, followed by a QRS complex, which is narrow complex. Then there is another P wave followed by a QRS complex. Now the PR interval is progressively prolonged. So if we map out the PP interval, so there is a P wave here, then there is a P wave here. So this is a PP interval. So we know that there is another P wave. Yes, there is another P wave. And if we look at the PP interval, we can map the next P wave is here. And that is exactly where the T wave is. So basically the T wave and the P wave, they are fused together. So we cannot see in this particular ECG where that P wave is. And that is when we need the electrophysiological studies that can show what is happening in this area. So if we look at only this particular area, it's going to be very difficult to differentiate between the Mobius type 1 and Mobius type 2. But if we look at this area, then that will give us some very concrete idea that actually there is progressively prolonged PR interval. And if you look at here, this PR interval that is quite prolonged from the usual PR interval. So this is a progressive prolongation of the PR interval followed by a non-conducted P wave. So this is a Mobius type 1 or Weng-Bache's block. All right. Now this is going to be really hard, but I'm pretty sure that Becky can help us in interpreting this ECG. Thank you.
Well, this is a complicated ECG, Avijit. Still, I think I'll give it a try. As always, let me interpret this ECG in a very systematic way so that I don't miss any important piece of information. The elephant in the room in this ECG is non-conducted P waves suggestive of a second-degree heart block. I will come back to it in a second. Let me talk you through the usual stuff at first. The atrial rate in this ECG is 84 beats per minute. The ventricular rate is 48 beats per minute. Every alternate P wave is followed by a QRS complex. In other words, there are intermittent non-conducted P waves, which makes me wonder if it is a second-degree heart block. The QRS complexes are regular. Now, the axis of the QRS complexes is about minus 45 degrees. In other words, there is a left axis deviation. The P wave is wide and bifid, which signifies left atrial hypertrophy. The PR interval is constant. There are regular non-conducted P waves. In this ECG, we have one QRS complex for every 2 P waves. Therefore, there is a 2:1 second-degree heart block. It can be quite challenging to say whether this is Mobitz type 1 or Mobitz type 2 simply by looking at the ECG. An electrophysiology study may be useful to come to an conclusion. Now, the QRS complexes are narrow complex and regular. The ST segments are isoelectric. The T waves are normal. The QTC is about 400 milliseconds, which is normal. The AVR lead looks reassuring to me. There is poor R wave progression in V3, which may be due to myocardial ischemia. Now, to compile all these information together, I am of the impression that the patient has a fixed ratio second-degree AV block. It is challenging to state if it is Mobitz type 1 or Mobitz type 2. Further electrophysiological studies may be mandated. I am a little concerned about this patient. My immediate action would be to seek and treat the underlying cause. For example, the patient may need further workup from myocardial ischemia point of view. However, in a fit and well-healthy athletic person, this may be a completely normal finding with a very good prognosis.
Absolutely. So another very good, thorough interpretation of this 12-lead ECG. So this is one of those difficult ones. So obviously, because of the non-conducted P wave, this is a second-degree heart block. But we do not know whether it is the Mobius type 1 or Mobius type 2. So usually in Mobius type 1, the QRS complex is narrow complex. And in Mobius type 2, it is wide complex. So probably this is a Mobius type 1. But again, if it is Mobius type 2, that can be quite a serious condition. So I think I will still get a cardiology consult for this particular patient. Because if it is Mobius type 2, they will probably need a pacemaker. Not all the time, but sometimes. So once again, particularly if we look at the P wave is wide and bit bifid. That usually happens if there is a left atrial enlargement or left atrial hypertrophy. And again, if we look at the P wave followed by a QRS complex, then P wave followed by no QRS complex, then there is a P wave followed by QRS complex, P wave followed by no QRS complex. This is a classic presentation of the second degree heart block. Probably it is Mobius type 1. Now this is another one. So in the previous ECG, we have talked about what we call a fixed block, fixed rate block. So for every certain number of P wave, there is one QRS complex. So similar type of ECG is this, and that was a very good one. Becky, could you please talk us through the ECG as well, this one? Thank you.
Oh, no. This is another complicated ECG. Still, I think I'll give it a try.
Yes, please.
As always, let me interpret this ECG in a very systematic way so that I don't miss any important piece of information. The elephant in the room in this ECG is non-conducted P waves suggestive of a second-degree heart block. I will come back to it in a second. Let me talk you through the usual stuff at first. The atrial rate in this ECG is 150 beats per minute and regular. The ventricular rate is 36 beats per minute and regular. For every 4 P waves, there is one P wave which is followed by a QRS complex. In other words, there are intermittent non-conducted P waves, which makes me wonder if it is a second-degree heart block. The QRS complexes are narrow and regular. There is some subtle right bundle branch morphology of the QRS complexes. Now, the axis of the QRS complexes is about -60 degrees. In other words, there is a left axis deviation. The P wave is normal. The PR interval is constant, though there is nothing to compare to say if there is prolongation of PR interval or not. There are regular non-conducted P waves. In this ECG, we have one QRS complex for every 4 P waves. Therefore, there is a 4:1 second-degree heart block. It can be quite challenging to say whether this is Mobitz type 1 or Mobitz type 2 simply by looking at the ECG. An electrophysiology study may be useful to come to an conclusion. Now, the QRS complexes are narrow complex and regular. There is subtle ST segment depression in leads V3 and V4, which may be due to anteroseptal ischemia. The T waves are normal. The QTC is about 400 milliseconds, which is normal. The AVR lead looks reassuring to me. Now, to compile all these information together, I am of the impression that the patient has a fixed ratio second-degree AV block. It is challenging to state if it is Mobitz type 1 or Mobitz type 2. As the QRS complexes are narrow, it is likely to be a Mobitz type 1 second-degree heart block. Further electrophysiological studies may be mandated to come to a meaningful conclusion. I am a little concerned about this patient. My immediate action would be to seek and treat the underlying cause. An urgent cardiology consult may be useful.
Absolutely. So this is one of those hard one. So only thing we can see is that the P wave is coming in every second large square. So the atrial rate is about 150 beats per minute, and the ventricular rate is very slow, about 40 beats per minute. So the main thing here is that the PR interval we cannot compare because there is no subsequent PR intervals. So there is a P wave followed by no QRS complex, P wave followed by no QRS complex, P wave followed by no QRS complex, and it goes on and on and on. Now this one is very important. So this is just a rhythm strip. This is not a 12-lead ECG. What we can see here is that there is a white QRS complex. Definitely this is white. Then there is a P wave followed by no QRS complex. So we know that this is a second-degree heart block. Then there is a P wave followed by a white QRS complex. Then there is a P wave followed by another white QRS complex. Then there is a P wave followed by no QRS complex. So there is a P wave followed by no QRS complex. So this is probably about, what I can say, 4:2. For every 4 P wave there are 2 QRS complex. But what is most important is, number one, the PR interval is constant, and number two, the QRS complex is wide. So this is Mobius type 2 heart block. So let's map the P waves once again. So there is a P wave here, then there is a P wave here, and if we look at the PP interval, this is pretty much similar. So the PP interval is same, and this is coming in every constant intervals. But because the block is below in the lower down conduction system, like in the lower part of the AV node, or maybe even in the bundle of His or right bundle branch, left bundle branch, or even at the level of the Purkinje fibers. So this type of block is very important in the sense that they can collapse, they can develop complete heart block. They usually need a pacemaker. Right, so let's focus why the patient is having this second-degree heart block. Is it physiological? Is it congenital? Is it because of some other problems? So to keep the life easy, we have got this mnemonic, something called the DIMES. So here the D stands for drugs. There are some drugs like the beta blockers, calcium channel blockers, especially we are talking about non-dihydropyridine group of calcium channel blockers like diltiazem or verapamil. But if the patient takes calcium channel blocker with a dihydropyridine group of calcium channel blockers like nifedipine, amlodipine, felodipine, it's not going to happen. They don't develop the second-degree heart block. So only the non-dihydropyridine group of calcium channel blockers, they can develop second-degree heart block. Digoxin, because what happens is digoxin does not cause a second-degree heart block, but digoxin can stimulate the vagus nerve, and vagus nerve then increases the atrioventricular delay, and that can cause second-degree heart block, either Mobius type 1 or Mobius type 2. Then I for ischemia or inflammation. So if the patient has got myocardial ischemia or myocardial infarction or inflammation like myocarditis, they can develop the second-degree heart block. It can be again Mobius type 1 or Mobius type 2. Usually, if there is infarction, that causes Mobius type 2, and if there is ischemia but not infarction, they develop Mobius type 1. But again, that is just a generalized perception. It is not true 100% of the cases. Mechanical causes, for example, if there is myocardial fibrosis, the conduction system can be affected in the fibrosis, and in that case they can develop the Mobius type 1 or Mobius type 2 heart block. We have seen quite a few patients with cardiac surgery like mitral valve surgery, open heart surgery. They can develop the Mobius type 1 heart block. Sometimes they can develop Mobius type 2 heart block as well, and they end up having pacemakers. The commonest electrolyte abnormality that we are worried about is hyperkalemia, and hyperkalemia can cause prolonged PR interval. Sometimes it can be very tricky because if there is hyperkalemia, the P wave may be absent, so we cannot detect the PR interval at all. There are some structural conditions. The most common one is the athletes. So in case of the fit and well young athletes, they can have increased vagal tone, and that can cause bradycardia, and that can cause prolonged PR interval. And if there is progressively prolonged interval followed by a non-conducted P wave, that is Mobius type 1, or if there is constant PR interval followed by a non-conducted P wave, that is Mobius type 2. So in summary, we have got five big boxes. These are drugs, ischemia, mechanical, electrolyte, and structural.
Dimes mnemonic. Here, D stands for drugs. I for ischemia or inflammation. M for metabolic or mechanical. E for electrolytes. S for structural. This mnemonic can be used anywhere and everywhere. Easy peasy.
Absolutely. So once again, D for drugs, I for ischemia or inflammation, M for mechanical or metabolic, E for electrolytes, especially hyperkalemia, and S for structural. If you use this mnemonic, you can remember most of the conditions that are causing the problems in case of the second degree heart block. Right, so the most important slide in the whole tutorial is the difference between the Mobius type 1 and Mobius type 2, and people ask me, people discuss about it, debate about it. Let's keep it very simple. You can take a snapshot of this page and you can use it for your study. So the most important finding in Mobius type 1, as we have shown you several ECGs, I have showed you animations, that in Mobius type 1 there is progressive prolongation of the PR interval, and in Mobius type 2 the PR interval is constant. Now in up to date they have talked about the RR interval. So they say that the subsequent P wave comes earlier than expected, and so the RR interval is shortened. It can be very difficult to identify this finding in a 12-lead ECG until unless you are very careful about it. So in Mobius type 2, on the other hand, the RR interval is constant. Usually, not always, in Mobius type 1, the block is at the level of the V node. But in Mobius type 2, the block is below the conduction system, in the lower part of the conduction system, below the V node, like in the bundle of His or right bundle branch, left bundle branch, and so the QRS complexes are wide. In Mobius type 1, because the block is at the level of the V node, QRS complex is narrow complex, but in Mobius type 2, the QRS complex is wide complex because the block is below the AV node, maybe in the bundle of His or in the right bundle branch, left bundle branch, even in Purkinje fibers. Now, this is very interesting. In up to date, they have got some discussion about it, that if we find that there is a dropped P wave or non-conducted P wave, if you look at the RR interval from before and after, that is not multiples of RR interval before. But in case of the Mobius type 2, if you find a drop bit or non-conducted P wave, identify the RR interval before and after R waves, and you will find that that particular RR interval is multiples of the RR interval prior to that. I'll show you some more ECGs later and we'll explain this particular finding. That is very interesting. Now, as I mentioned, the commonest cause of Mobius type 1 is myocardial ischemia, but not infarction, and drugs like beta blocker, calcium channel blocker, digoxin. In Mobius type 2, usually myocardial infarction, fibrosis, necrosis, they are the common causes. But again, that does not happen 100% of the cases. We have shown you one 12-lead ECG where there is an inferior STEMI, inferior myocardial infarction, but they have got just Mobius type 1, not Mobius type 2. Atropine can be given if the patient has got severe bradycardia and symptomatic in Mobius type 1. But if you give atropine in Mobius type 2, they can develop complete heart block. They can even die from asystole. So be very careful. Do not give atropine if you are not sure if it is Mobius type 1 or Mobius type 2. In Mobius type 1 it is safe, but Mobius type 2, that can be fatal. Usually Mobius type 1 is physiological. It can be found in athletic patients and it is benign. If the cause is drugs, stop the drug. If it is myocardial ischemia, treat that ischemia. In Mobius type 2, however, they can lead to complete heart block. So usually they need admission to the hospital and sometimes they need pacemaker. In Mobius type 1, identify the cause and treat it. And in Mobius type 2, usually they need cardiology consult and probably they will need a pacemaker. So the summary, if we know the cause, we can treat it. So in Mobius type 1, as we have mentioned, patient can be asymptomatic, it can be physiological, we don't have to do anything. They need follow-up in the outpatient clinic or with the cardiology or with the even by the GP. But in Mobius type 2, that is more serious. So they need cardiology admission, they need pacemaker, and please do not give any atropine because that can cause complete heart block and even asystole. So we have come to the last slide. So in summary, Mobius type 1 is a progressive prolongation of the PR interval followed by a non-conducted P wave. Mobius type 2 is a constant PR interval followed by a non-conducted P wave. We need to identify the cause and we need to treat it. So, Becky, could you please summarize everything for us in a few lines? That will be fantastic. Thank you very much.
Absolutely. Okay guys. It's time to wrap up now. The second-degree heart block is an interesting concept. There are intermittent non-conducted P waves in the second-degree heart blocks. There are two types of the second-degree heart blocks. These are Mobitz type 1 and Mobitz type 2. In the Mobitz type 1, the PR interval progressively prolongs followed by intermittent non-conducted P waves. At the same time, the RR interval progressively shortens. Usually, the block is at the AV node. Therefore, the QRS complex is narrow. Another very interesting aspect of the Mobitz type 1 block is that the RR interval surrounding the dropped P wave is not multiples of sinus RR intervals. The progressive suppression of the AV node such as the reversible myocardial ischemia, drugs such as beta blockers, calcium channel blockers are the commonest causes of the Mobitz type 1 heart blocks. Athletes may have Mobitz type 1 heart block. Atropine is used for the treatment of Mobitz type 1 heart block. Usually, the Mobitz type 1 heart block has a benign cause. We need to seek and treat the underlying cause. On the other hand, in the Mobitz type 2 heart block, the PR interval is constant followed by intermittent non-conducted P waves. The RR interval is constant too. Usually, the block is below the AV node such as at the level of the Purkinje fibers. Therefore, usually, but not always, the QRS is wide complex in Mobitz type 2 heart blocks. The RR interval surrounding the dropped P wave is multiples of sinus RR interval. Myocardial infarction, myocardial fibrosis, and myocardial necrosis are the commonest causes of Mobitz type 2 heart block. We need to be very careful not to use atropine in this case of Mobitz type 2 heart block, because it may cause fatal outcomes such as asystole and even death. The Mobitz type 2 heart block tends to lead to a complete heart block. Therefore, they need hospital admission for permanent pacemaker. That is all I have to say about second-degree heart block. Hope that helps. We have a huge collection of second-degree heart block ECGs that we will show you in the subsequent videos. Watch the space.
Absolutely. So we'll have some case-based discussion, and we'll have I've got probably about almost 100 ECGs of both Mobius type 1 and Mobius type 2. Not many Mobius type 2, but quite a few Mobius type 1. So we can discuss about them in the subsequent videos. Thank you. Now there are a lot of literature, a lot of medical articles on the Mobius type 1, Mobius type 2 second degree heart block. I found the best summary is probably in UpToDate, but also there are quite a few ECGs in Life in the Fast Lane web page. Alright, so we have come to an end. If you've got any questions, please drop me a line and I'll be very happy to answer the questions. You can get in touch in Twitter, through email, or in my web page. And thank you, Becky, for interpreting this ECG in a very succinct, comprehensive way. If everybody interprets the ECG in that way, they will not forget or miss the important findings, so that we can pick up the important stuff and we can identify the problem, treat the problems. That will be really, really good for the parents. Thank you very much, everyone. Thank you, Becky, for being with us.
Okay, folks. Thank you for watching the video. Hope you have enjoyed the video. You are so awesome. If you find it useful, please like the video, subscribe to the channel and share it with others. Please write comments below the video. For every comment that you write, positive or negative, I will personally give a cookie to my cat Lucy. I promise I will do. If you have any burning questions, constructive suggestions or some awesome ideas, please get in touch. We would love to hear from you. Your comments and suggestions are very important to us. You can contact us through email, Twitter or Dr. Barai's webpage. Thanks once again. See you soon. Bye for now.